Hi, I'm Jack Farr. I'm going to be discussing large and pre-arthritic lesions with Brian Cole. Brian, we've talked about small and medium in the past. Now we're going to these large lesions and maybe even pre-arthritic lesions. We have partners that'll come in over our shoulders and look and say, that's arthritis. Why are you treating that with cartilage? What do you do with these large lesions?
I mean, these are often different patient groups. These are patients that tend to be a little bit older. I think they often are less responsive to the things that we traditionally do in our younger groups. And I think we have learned over time that we have to be a bit cautious in the solutions we can offer our younger patients, mainly because I think the physiology is very different. The good news is that we can stretch the limits, I think, first with allograft tissue when need be, being extremely mindful that many of these patients are more commonly associated with comorbidities. So this is one where the lowest hanging fruit, I think, is being malaligned. Our best results historically have been if you've given the opportunity to correct malalignment, that patient is much more likely to do well than a normally aligned patient who's pre-arthritic. So having that in the bag is particularly helpful. Allografts, as I alluded to, I think have really, at least in my practice, been the mainstay. Now with instrumentation, the so-called BioUni, it allows us to deal with these oblong arthritic lesions, which are really things that happen over time. They're not the short-lived, I've been living with pain for 6 months or less. These are patients who have had this for a long time who may have then become symptomatic. So I think we have options, but I think we also have to remain mindful of how far we can push the envelope and not forget about non-surgical treatment. So this is that crossover point where you have to say, look, when the rubber meets the road, when do we pull a surgical solution versus trying to carry these people along until they're properly sequenced for a partial replacement, for example.
You mentioned that these were sort of the pre-arthritic, as I did. And so let's talk a little bit about age, because that kind of, the older they are, the more arthritic they are, or pre-arthritic. Yeah. Certainly under 40, I have a tendency to try everything biologic possible that's in my bag.
Yeah.
Over 50, any more unicompartmentals, patellofemoral arthroplasties are doing reliably well when performed properly, that I don't want to put them through the long recovery of a biologic.
Right.
And it's the 40 to 50-year-old that I have to look more at their physiology, what they want to do, what's their job, can they take off 6 months of low load bearing activities. Yeah. What about salvage types of procedures? Is osteochondral allograft your go-to for all your salvages?
It really is, because most of these patients have subchondral change. They're very load-related pain. Sometimes they're biologic pain, if you will, too. In other words, they have effusions, they have barometric symptoms, they have achiness. Those patients are not always load-related, but suffice to say, the more we can replace with normal, healthy osteochondral unit, I think the better they're going to do. But again, remaining mindful that many of these are malaligned. They may be slight varus, they may be trace valgus. Those are the ones that, especially if they have load or weight-bearing pain, they do much better than when they're normally aligned. So if you can realign them and then take care of the biologic issue, that can be a home run. But as you alluded to, it's a very patient-centered approach. Just because they have a specific disease, that doesn't mean the same solution will match every patient. Some of these patients have been through 2, 3, 4 operations, and we always have to remain mindful. What do they want to go through to get this done?
So we both see these patients, they come in and they have almost no joint space. It is theoretically possible to do a bipolar osteochondral allograft. If they're 48 years old, do you pass them on to your arthroplasty doctor? Or what do you do?
If they're in varus, I may consider osteotomy, but I've learned over time that if you're dealing with a 50% success rate, and like you alluded to, if they're on crutches 6 to 8 weeks, and the amount of times it takes to get better and so forth, when my partners do arthroplasty are doing them as outpatient procedures, they're immediately full weight bearing. There's far narrow window in terms of variability and outcomes. I would much prefer them to go on to arthroplasty when they're in that state. I know they're young, but it's inversely related to their misery factor. The more miserable they are, the more willing I think they're to undergo an arthroplasty.
Yes, sometimes you just have to say no and admit that we cannot treat everything.
Right.
Thank you very much.
Thank you.